Okay, now what we will discuss now is phakomatosis, a very important subtopic under genodermatosis. Okay, very important subtopic under genodermatosis, the phakomatosis. This is also known as oculoneurocutaneous syndrome. Oculoneurocutaneous syndrome. As it is implied from the name, that is, all of the diseases have some ocular features, some features involving the nervous system and some involving the cutaneous system. So first we will discuss the very common entity, neurofibromatosis. Neurofibromatosis. There are two types of neurofibromatosis, type 1 and type 2. Okay, both of them are autosomal dominant. Both of them are autosomal dominant. Now, the gene responsible for the diseases is neurofibromin. Neurofibromin for type 1 neurofibromatosis, and it is Marlin or schwannomin for type 2. The neurofibromin gene is located in chromosome 17 and the Marlin or schwannomin gene is located in chromosome 22. Okay. The type 2 is characterized by bilateral acoustic schwannoma. Bilateral acoustic schwannoma. Okay. Now the type 1, the more common one, is the type 1. Okay, this is diagnosed by using a criteria. There are certain points among which more than equal to 2 should be present for diagnosis of neurofibromatosis type 1. Okay. Now first criteria is neurofibroma. Okay, first is neurofibroma. There must be more than equal to 2 neurofibroma. They are soft nodule present over skin. Okay, important feature of neurofibroma is the buttonhole sign. As it is a soft tumor, when it is pushed, it goes into the panniculus. When it is pushed down, it goes into the panniculus, that is subcutaneous fat. This is known as buttonhole sign. Okay, so more than equal to 2 neurofibroma is a diagnostic feature. Next, if it is a case of plexiform neurofibroma, this is a plexiform neurofibroma. See, this one is plexiform neurofibroma. Presence of a single plexiform neurofibroma is sufficient for diagnosis. Okay. Plexiform neurofibroma has a bag of worm appearance on palpation. Okay. So first is neurofibroma. Second is cafe au lait macule. Cafe au lait macule. Hyperpigmented macule. Okay. If it is more than 6 in number, then it is a diagnostic criteria. Along with the number, the size is also mentioned. The size must be more than 5 millimeter in prepubertal children, and it must be more than 15 millimeter in postpubertal. Okay, it must be more than 15 millimeter in postpubertal. Now, regarding the shape of cafe au lait macule, there are two entities. One is called coast of Maine, that is the rough border. This is the feature of cafe au lait macule of McCune-Albright syndrome. McCune-Albright syndrome. Another is coast of California. Coast of California, that is the smooth border. This is the feature of cafe au lait macule of neurofibromatosis. Remember these two: coast of Maine, coast of California. Okay. Now, here you have to remember one important thing, that is the most common initial manifestation of neurofibromatosis type 1 is cafe au lait macule. Okay. Now, the third one. Freckling. Freckles, axillary or inguinal freckles, if present, they forms a diagnostic criteria. The axillary freckles is also known as crow sign. Okay, so known as crow sign. This is axillary freckling here. Let's see, look here, axillary freckles are present. Okay. Next is optic glioma. If present, this is one diagnostic criteria. Next, leish's nodule. This is nothing but iris hematoma. This is iris hematoma. If it is present in 2 or more in number, then this also forms a diagnostic criteria. See, here is the leish's nodule. Okay, these are the leish's nodule. What are the other diagnostic criteria? Number 6, specific osseous lesions, specific bone lesions. What are those? These are 3 in number. One is sphenoid wing dysplasia. Sphenoid, the wing of sphenoid, there is dysplastic changes. Sphenoid wing dysplasia. Okay. Number 2, thinning of cortical long bone. Thinning of long bone cortex. Okay. Number 3, pseudoarthrosis. And last is first degree relative having neurofibromatosis. Who are first degree relative? They are parent or sibling or offspring. Okay, so these are the 7 diagnostic criteria. Among them, if 2 or more are present, then this is diagnostic for neurofibromatosis. Okay, the most common phakomatosis is neurofibromatosis. Next we will move on to the second one, tuberous sclerosis. Second one, the tuberous sclerosis, also known as Bournville disease. Bournville disease, also known as epiloia. Epiloia, what is that? Epilepsy, low intelligence, and adenoma sebaceum. Okay, they are together called Vogt triad. Vogt triad. Okay, so this is a picture of adenoma sebaceum. What are the other features? See here. First and important one is facial angiofibroma. Adenoma sebaceum is basically a misnomer. Facial angiofibroma. This is the other name of adenoma sebaceum. Okay. Next. If it is more than 3 in number, it forms a diagnostic criteria. Or if there is a fibrous cephalic plaque. Fibrous cephalic plaque. A single plaque is also a diagnostic criteria. You don't need to remember all the diagnostic criteria of tuberous sclerosis. Just remember the features, the cutaneous features and the extracutaneous manifestations. Second is the ash leaf macule. Ash leaf macule. Okay, this is a hypomelanotic macule. Hypomelanotic macule. Okay, this is the most common lesion of tuberous sclerosis. Most common lesion is ash leaf macule. Okay, now third one. Third is the shagreen patch. Third one is shagreen patch. This is basically a plaque, not a patch. This is a plaque. Most common site is the lumbosacral region. Lumbosacral region. Okay, and this is histopathologically is collagenoma. Soft tissue tumor, collagenoma. Okay, next cutaneous feature is Quenin tumor. Quenin tumor, what is that? This is periangular fibroma. You can see here presence of periangular fibroma. Periangular fibroma or Quenin tumor. Okay, next, this is confetti macules. Okay, this is confetti macules. Wide distribution of hypopigmented macules throughout the trunk. This is confetti macules. Okay, next. What are the extracutaneous manifestation of tuberous sclerosis? Starting from head to toe, we will see first CNS. What are the CNS involvements? There will be cortical tuber. Next, there will be subependymal nodule. There will be subependymal giant cell astrocytoma. Okay, on CT scan of subependymal nodule, it is termed as candle wax dripping. Candle wax dripping. Candle wax dripping appearance. Okay, next, after CNS, we will next see eye changes. There is retinal hamartoma and retinal achromic patch. Retinal achromic patch. Okay, next, in teeth there is dental enamel peats. Dental enamel peats. Next, in heart there is rhabdomyoma. Okay, lungs, there is lymphangioliomyomatosis. Lymphangioliomyomatosis. Okay, next, kidney, there is angiolipoma and renal cysts. Okay, now treatment. There is a new agent for adenoma sebaceum. Treatment for adenoma sebaceum is rapamycin. What is that? This is mTOR inhibitor. Rapamycin, topical rapamycin. This is used for adenoma sebaceum. Okay, now next we will see next disease, von Hippel-Lindau. Von Hippel-Lindau syndrome. Okay, this is also autosomal dominant. Okay, just a minute, we have missed something in tuberous sclerosis, the genetic part. We have missed the genetic part of tuberous sclerosis. Let us recapitulate here. Yeah, there are two genes responsible for tuberous sclerosis. Okay, they are TSC1 and TSC2. TSC1 and TSC2. Okay, TSC1 is located in chromosome number 9. TSC2 is located in chromosome number 16. What are the different protein they produce. The TSC1 gene produces hamartin, and TSC2 gene produces tuberin. Okay, this is also autosomal dominant disorder. Autosomal dominant. Okay, TSC1 present in chromosome 9, TSC2 present in chromosome 16, and the protein they produce are hamartin and tuberin. Okay, next what we are discussing, von Hippel-Lindau. Von Hippel-Lindau syndrome, this is autosomal dominant, another autosomal dominant disorder. Now you have to remember VHL here, VHL. Okay. VHL gene is responsible. It is present in chromosome 3. Next, H. There is hemangioblastoma. Hemangioblastoma. We get cerebellar hemangioblastoma. Okay. Next, L. There is lots of catecholamine. That is pheochromocytoma. Pheochromocytoma associated with von Hippel-Lindau. Malignancy associated with von Hippel-Lindau is renal cell carcinoma. Renal cell carcinoma. Okay, next disease is ataxia telangiectasia. Ataxia telangiectasia. This is autosomal recessive. So far we have discussed all were autosomal dominant. This is autosomal recessive. The gene responsible is ATM gene present in chromosome 11. ATM gene present in chromosome 11. What are the characteristic features? There will be cerebellar ataxia. Okay. There is oculocutaneous telangiectasia. As it is implied from the name, there will be telangiectasia. And there will be sinopulmonary infection. Okay, these are the features of ataxia telangiectasia. Next, Phakomatoses is Sturge-Weber syndrome. Sturge-Weber syndrome. Okay, here the inheritance is sporadic. It is a sporadic disease. This is also known as encephalo-trigeminal angiomatosis. Encephalo-trigeminal angiomatosis. Okay. What you will expect here, the cutaneous features here is port wine stain present at birth. See, this is the port wine stain, and it involves the ophthalmic maxillary, sometimes mandibular division also. Okay, next, what are the CNS features? There will be leptomeningeal angiomatosis. Okay, leptomeningeal angiomatosis, this is responsible for epilepsy, mental retardation, hemiplegia, hemisensory defect, and homonymous hemianopia. Okay, these are the features of CNS involvement in Sturge-Weber syndrome. Okay, now as it is encephalotrigeminal angiomatosis, you can expect some eye changes also. Okay, in CT scan, this leptomeningeal angiomatosis give a drum track appearance. Okay, now the ocular features of Sturge-Weber syndrome. There will be glaucoma, leading to ophthalmos, and retinal detachment. Okay, so these are the Phakomatoses that we have discussed: neurofibromatosis, tuberous sclerosis. These are two important. Then von Hippel-Lindau, ataxia telangiectasia, and Sturge-Weber syndrome.